You can start, doctor.
Yes, I am ready. So, the second lecture is about our experience to treat very difficult and very rare disease in the children. So, as everyone knows, in the children, most often tumors. What we have, this is a craniopharyngiomas, which is localized in a skull base or in the third ventricular and spreading in the basal systems. Ependymomas, which is localized in most of the cases in a third ventricular optic pathway gliomas, astrocytomas, and colloid cysts. The choosing of the approaches is based on the Yasher classification. In most of the cases we used, and it's enough to using terional or lateral subfrontal approaches if the tumor is localized in a cellular region, spreading in an interpendicular systems or in the basal systems. Anterior interhemispheric transcallosal approach with some modification we used if the tumor is localized in the lateral or in the third ventricular. In most of the cases, we use a prone position. In some cases, we use a lateral position, some gravity traction, which allows us to operate it without retractors. So in the last decades, there is very development of the endoscopic transnasal approaches, but in the children, because of the small sizes of the nose, some sphenoidal sinus, large tumors localized in a cellular and skull base area, it's more difficult to operate it by transsphenoidal route. In spite of, we have experience to operate it many pituitary adenomas in the adults, but in the children population, there is some technical difficulties. So that's why in the children, we always used transcranial approaches. So let me show you some difficult cases. It's a large supralateral cellular craniopharyngioma, which was operated used the lateral subfrontal approach, which it was suitable, it was enough, and gross total removal was achieved. It's a postoperative scan without any complication. This is another case is also supraretrocellular large craniopharyngioma. In these cases, we also used terional approach, and gross total removal was achieved without some visual disturbances, only temporary some diabetes insipidus exists after operation. This is also craniopharyngioma and supraretrocellular. In these cases, we also used terional approach, which is a brilliant approach, and it's enough to operate it, such kind of cases. It is a postoperative scan. It's a subventricular craniopharyngioma. In these cases, we used transcallosal approach through the foramen of Monroe, and whole tumor was gross totally removed. It's also subventricular craniopharyngioma localized in the third ventricular. In this case, is also transcallosal approach was suitable and gross total removal was achieved. This is a very difficult cases of giant optical glioma. In these cases, subtotal removal was achieved using by terional approach. This is a third ventricular ependymoma. In these cases, we also use the transcallosal approach. It was enough. It was a suitable, appropriate, and full tumor was removed. It's a postoperative scan without any serious complication. This is a colloid cyst. It's not a difficult case to compare with some another tumors, and in these cases, also radical removal was achieved. It's a postoperative scan. This another case is of the ependymoma. It's localized holes through a third ventricular, and transcallosal approach was suitable, and this tumor was also completely removed. It's a postoperative scan. This is a choroid plexus papilloma operated by transcallosal route, and whole tumor also was completely removed. It's a postoperative scan. In some cases, where the tumor is localized on the skull base, in the lateral and subventricular, we use combined approach, transcallosal and pterygium approach, which is more suitable to achieve gross total removal. In such cases, large cranipharyngioma was removed using combined approaches. It's an ependymoma localized in a posterior part of the third ventricular. In these cases, we used transcallosal subchoroidal approach to give access of the posterior part between the fornix and between the plexus. It was enough, and gross total removal was achieved. Transcallosal transchoroidal approach. This is more difficult cases, very large tumor localized in the thalamus and spreading in the midbrain. In these cases, we also use transcallosal subchoroidal approach, removing the part of the tumor localized in the right thalamic region, and then remove the part of the tumor localized in the midbrain. The radical removal was achieved without serious complication. So during the last 5 years, we operated about 50 cases. In most of the cases, we achieved total removal. Fortunately, we have not the mortality, and some complication was about the morbidities or some insipidus in cranipharyngioma surgery, or some visual or some mild neurological deterioration, mostly temporary. Thank you once again for attention. It's our capital city, Tiflis. So another part, it was a supratentorial approaches. Now I was trying to show second part is the infratentorial tumors. So there is a classic, there is a distribution by histology. Medulloblastoma is most often tumor in a posterior fossa, ependymoma, astrocytoma, choroid plexus tumors, or others. In most of the cases, the suboccipital median craniotomy it's suitable, appropriate, operate the tumors if they are localized in the fourth ventricular, in the vermis, or some basal systems. In most of the cases, we used in a children only prone position, and it's more ergonomic, it's more suitable for me. Occipital transterritorial approach we used not in very rare cases when the tumor is localized in an upper vermis and the angle of the tentorium is very stiff. In these situations, we use occipital transterritorial approach in a lateral decubitus position. Supracerebral approach in a young child, we prefer prone position, and in the older child, there is possibility to use semi-sitting position. Infratentorial tumor, in most of the cases, the aim is a total removal. We often use intraoperative neurophysiological monitoring. The restriction of radicality, it depends on the anatomical correlations, the tumor and the brainstem structures. Cellular approach we use if the tumor is spreading in a lateral recess. So I will show some cases. This is a young child with a forced ventricular medulloblastoma. We used medial suboccipital approach, and total removal was achieved. This is a pilocytic astrocytoma localized in a forced ventricle. Also, we used medial suboccipital approach, and radical removal was achieved. It's a postoperative scan. These are ependymoma cases. It's localized in a forced ventricle and spreading of the lateral recess, and televal approach was suitable, and radical removal was achieved. It's a postoperative scan. It's another large cases of the medulloblastoma. Fortunately, the radical removal was achieved. These are difficult cases, brainstem hemangioblastoma, but surgery was successful without any serious complication. This is a brainstem astrocytoma. We used suboccipital televolar approach. The tumor was localized in a inferior part of the forced ventricular, in the inferior stem of the cerebellum, and it was spreading in a lateral recess of the forced ventricular. This subtotal removal was achieved after operation. The patient gives radiosurgery. This is a large forced ventricular and is a brainstem area. This is a postoperative scan. Radical removal was achieved. We used the suboccipital median craniotomy. This is a large pilocytic astrocytoma localized in a forced ventricular and in a lateral recess of the forced ventricular. Total removal was achieved. This is a pilocytic astrocytoma. We use supracerebellar approach by prone position, and also gross total removal was done. This is a brainstem glioma. Because of the infiltrative nature, we cannot remove this tumor completely, and some part of the tumor was left on the brainstem, and subtotal removal was achieved in these cases. This is a choroid plexus papilloma. Radical removal was achieved with preservation of cranial nerves. This is a postoperative scan. This is a large ependymoma, and gross total removal achieved. This is a very difficult cases. It's a neurofibromatosis type 1, and this was a fibrillar astrocytoma localized in the medulla oblongata. And fortunately, radical removal also was achieved. This is an anaplastic ependymoma. Also, successful removal without serious complication was achieved. This is a large medulloblastoma. In these cases, subtotal removal, only small part was left. And after the operations, the patient gives a chemotherapy. This is a very difficult territory tumor. This case was operated in another hospital. They cannot remove it completely, and the patient was admitted in our department. and successful total removal was achieved. Result in more than 40 cases, in most of the cases, we achieved total removal. We unfortunately have one cases, one mortality by some infection complication, and morbidity was in most of the cases temporary, not permanent. Thank you once again for your attention. I'm ready to ask your questions. Thank you.
No, thank you, doctor. We really appreciate how you work, as I said a little bit earlier. So, well, I have only one question for you.
Yeah.
Just which one of the types of tumor that you have seen over the years will you say that it's the most difficult to operate?
Very good question. You know, the difficulties is depending some factors, um, especially in a young children's. To compare the surgical techniques in adults, there is some serious factor because you cannot lose of the blood. You know, in a small child's, there is a very serious restriction. In adults, you have some possibilities to operate it more safely, to lose maybe 1 liter blood. But in a young children's, it's very difficult. So the surgical techniques, that's why it's different. That's why if the tumor is very bloody, if the tumor is very vascularized, it's very serious problem in the children. So the vascularity of the tumor, it's important factor when you are planning surgical removal. Another factor, it's not size, but some consistency of the tumor. Because if the tumor is soft, it's more easier to suck. But as I mentioned above, the surgical techniques, it's different when you operate a small child than when you operate the adults. Because in adults, you can use the surgical techniques in out. But in a child, you also try to operate it out in. So first of all, you should dissect, you should devascularize of the tumor by the surrounding of the tissue. That's why the consistency of the tumor, it's a serious problem. And of course, the localization of the tumor, it's also a serious factor. So this factor is it's important when you are planning, if you are to explain which cases it's a difficulty. It depends on the vascularity, it depends on the localization of the tumor, and it depends on the consistency of the tumor. It's my opinion.
All right, so thank you very much. We really appreciate that. If you don't have anything to add, I guess that it's all for today for your part. So we really appreciate that. In name of all the people that works in this Congress, we really appreciate that you had the time to come here and explain everything to us. So